DR, a novel energy-discriminating flat-panel X-ray detector for point-of-care and bedside imaging. My name is 𝘚𝘱𝘚𝘐𝑒𝑚, and I'm the Chief Technology Officer for 𝘚𝘚 Imaging. The company, a little bit of a background, was incorporated in 2015. It's got about 35 full-time employees. The technology was developed at the University of Waterloo over the past decade in Canada and commercialized by the company. We've got 80 global patents. 20 of them are unique in the United States. They've all issued, so the technology is patent protected. The detectors actually have FDA, CE, Canada, Taiwan, Australia clearance for use. And we have a 9,000 square foot facility in Waterloo where we design and test. And we also have a contract manufacturer who builds these in large volumes. So, what's the main drawback of X-ray? Why are we talking about spectral DR? The main problem with X-ray is that X-ray is not able to separate materials, for example, calcium or water. If, for example, you look at this image on the screen here, you can see that there is some kind of a nodule here, but you couldn't say with certainty if it's calcified or not. In fact, most of the time you would say, I need to go for a follow-on CT. Some other problems with X-ray are poor quality, especially for portables. Portables, of course, are used to find line and tube tips, foreign bodies in the OR, pneumothorax, pneumonia in the ICU. All of these are kind of hard to pick up on portables because they just generally have pretty bad image quality. The other part with X-ray is laterals are really underappreciated. They're not used very frequently. But the problem is the lateral is a huge opportunity. There's disease and potentially incidental findings in the retrocardiac space that are missed on a regular basis. Things like coronary calcium, overlapping masses, tuberculosis, so on and so forth. So all of these are missed opportunities for X-ray that spectral DR can help resolve. Now, what exactly is spectral DR technology? So the first thing is a little bit of a physics lesson. X-ray spectrum, of course, spans all the way from low energy to high energy, right? Dual energy subtraction, invented in the 1970s, was using different parts of the spectrum to differentiate materials. For example, you can separate calcium from water. Spectral DR technology is the most advanced version of dual energy. It's a single exposure, triple layer sensor that is able to perform dual energy in a single exposure. It can perform dual energy on any clinical view or technique. So you could be talking extremities, you could be talking KUB, chest, laterals, obliques, whatever. It's also the lowest dose X-ray detector out there. In fact, its dose is identical to that of a regular chest X-ray because you're still using the same kVMA as a regular X-ray. And of course, this device, as I mentioned, is cleared in multiple regions around the world. So the advantage of dual energy, of course, is that it requires two inputs, a low energy spectrum and a high energy spectrum, and it uses that information to separate material. So in the left, in the soft image, you've got water, and in the right image, you've got bone or calcium. With this separation, not only can you see the bones and the soft tissue better, you also have material discrimination ability. So it's an identification piece. You can identify images or features in the hard image have something to do with calcium, features in the soft image have something to do with water. Now, dual energy has been around for a while. There are dual exposure techniques that have been in the market for quite some time, but they usually require two exposures. They're not really suitable for lateral or obliques or other anatomies. They're usually only good for PA chest. Definitely not mobile. You need fixed systems for it. They're quite expensive. They're proprietary. And the image quality can be inconsistent. You get motion artifact that can make up even up to 20% of images. The challenge there, of course, is you're taking two images, so there's a chance of breathing motion or heart beating that actually ends up causing these type of streaks sometimes. So dual exposure solutions can't really replace X-ray. They're an add-on to X-ray. There's some two-layer single exposure dual energy techniques that are also starting to come in, but they also are beset with drawbacks. So they use two sensors, and that inherently creates a trade-off between the DR image, and the dual energy image. You also got higher radiation because you're forced to use non-standard kV, like a higher 130 kV, in order to get a decent dual energy image, so that's not going to replace X-ray. For example, a portable will typically use 90 kV. The views are also limited, typically only PA. For laterals, you may require even larger technique. And these are also not mobile because of the kV of the sources that are required. So the two-layer dual energy solutions are also not going to replace standard X-ray. They're an add-on to existing X-ray. So what do we do that's so different? Spectral DR is a triple-layer single exposure dual energy solution. And people say, why 3 layers? The reason for 3 layers is that you can acquire the DR image with very high quantum efficiency, but you can also get the dual energy images without changing the clinical technique, the dose, or any of the workflow. So the triple layer detector basically gives you 3 images for every exposure. You get your standard X-ray image, like everyone else, but with very high DQE. But you also get a soft tissue and the bone image. Device is approved for sale in 8 jurisdictions. You get portable, bedside, and fixed solutions. It's patent protected. You've got, for the first time, the ability to replace X-ray, not just be an add-on to X-ray, but a replacement for X-ray, because you're getting an X-ray with every exposure. You also get the dual energy with every exposure. It's compatible with any X-ray source, so you don't even need to change your infrastructure. And most importantly, it optimizes follow-on imaging for the first time. You can now choose to use your CT and your MR in a better, more effective fashion. So this is a nice pictorial that describes that. On the left, you've got CT, which has very good diagnostic accuracy, but low accessibility and cost effectiveness. On the bottom right, you've got mobile X-ray. It's very accessible. And the DR room, Spectral DR, allows mobile X-ray and DR rooms to start getting better diagnostic accuracy while maintaining accessibility and cost effectiveness. 1 shot, 3 images, no motion artifacts, same technique, same dose, same sources, better patient outcomes, and also better provider outcomes. So what do we mean by better outcomes? For the administrator, you've got quality improvements, you've got risk reduction, you've got time savings. You've also got optimization of imaging flows. You can leverage existing X-ray equipment, and multiple departments are benefiting. For the clinician, the big benefits are a 30% reduction in reading time. Counterintuitively, when you get multiple dual energy images, it actually reduces your overall reading time because the images are easier to read. You also get higher confidence, better inter-reader agreements, and perhaps most interesting for admins as well, incidental findings. For the technologist, it reduces your need to retrain. You can use existing X-ray equipment, full integration with the regular packs, same procedure and dose as just X-ray, and it's mobile. So you don't have to move your patients around the hospital unnecessarily, and you can potentially reduce the risk of falls. And for the patient, of course, the peace of mind that comes from early disease detection, and obviously the same procedure and dose as a chest X-ray, which is 20 times less than a standard CT. There's a number of clinical use cases that have been demonstrated, lots of clinical evidence for nodules, coronary calcium, pneumonia, pneumothorax, TB. If any of you are interested, there's a number of references that I can point you to that are published at various venues and journals and conferences. What I'll spend the rest of the few minutes that I have is I'll go through some clinical use cases that were interesting from our studies. So I'll start off with ICU. So in this particular case, this was a patient that was imaged for pneumothorax. In the conventional X-ray, of course, you can see the pneumothorax, but in the soft tissue image, it really becomes obvious. And this, as you can see, was taken as an AP portable in an ICU, and on the right-hand side is a bone image. Here's another AP portable, also taken in the same ICU. In this particular case, there's a clip that is sitting on top of a consolidation. So that tends to happen quite frequently. These foreign objects, clips, ports, etc., tend to obscure interesting pathology. With this type of dual energy, you can actually subtract clips and ports in the soft tissue image, so it's easier to visualize. The bone image, of course, highlights the lines and tubes very nicely, and we'll see some of that in a bit as well. So in this case, you've got line delineation again. A regular image, I've only shown the bone image here, and you can see, for example, the lines and tubes become very easy to see when the soft tissue is subtracted out. Here's another image, same kind of story. Lines and tubes on the left become much easier to see on the right-hand side. You can see all sorts. The tip, of course, very clearly. Okay, so beyond ICU, which is really bedside imaging, there are some interesting use cases for triaging and also for incidental findings. For example, in this particular case, this patient was actually a pneumonia patient. They had come in, the X-ray image was taken, and it was a lateral image. The radiologist, upon inspecting the bone image, noticed that there was coronary calcium sitting right there in the retrocardiac space. So this was a very interesting finding. When we went back and we looked at a bunch of other pneumonia cases, we were able to pick up coronary calcium in almost half of those patients. This coronary calcium invariably showed up in the lateral image. It was much harder to see on the PA image. This kind of emphasizes some of that hidden value of the lateral image that I had pointed out earlier. Here's another example, a patient that was imaged actually in the United States. Upon looking at the lateral image, there was some suspicion as to whether this is a mass. Upon inspection of the soft tissue and bone images, it was confirmed that the mass was really a harmless bony outcropping. And so this patient was sent home without need for a CT. Here's another case with pneumonia. Patient was imaged. The radiologists, both of them actually missed a focal opacity that was adjacent to this port right here. In the soft tissue image, you can see the focal opacity quite clearly. This was verified with the CT. This is another example of being able to pick up subtle features in the soft tissue image. There are many examples in the triaging case, and we can go through that at another time, but I'll also kind of conclude some of this with just some general radiography and point of care examples, just in case you're wondering, is this technology only good for chest X-ray? The short answer is it's actually good for all X-ray. So here, for example, is a cervical spine. The bone image kind of cleans it up quite nicely. One of our sites asked us this question because their CTs were being tied up unnecessarily for cervical spine imaging. With this type of device, of course, you can see the cervical spine easily, so you can reduce the backlog on CT. Here's another one. It's just a joint. But what's interesting in here is that there's actually foreign bodies, clips, that are in the joint. When you look at the bone image, these clips start to pop out. One of the interesting use cases with this type of device is in the OR. When you're sealing up the patient and you want to check for fine curved needles or sponges, you can use the bone image to get your peace of mind to know that you've actually found them. And lastly, this was just an interesting image. An orthopedic clinician tried an oblique on one of their patients, and I really liked it, so I just put it in. But in case you don't recognize the view, it is an oblique, and there's the soft tissue version. This fellow actually has a bullet lodged in their upper chest. And there's the bone image sitting right there. So that's, again, another advantage of single exposure dual energy. You can take any view, any body part, and benefit from the dual energy. So I'm going to conclude with just some of the future for this type of technology. What you've seen, this is now being used for portables and fixed, but there is a dynamic element to this that we can look at. For example, we've tried just on some phantoms, very simple tomosynthesis algorithms. And what you're seeing up there is actually dual energy tomosynthesis using single exposure. One of the first demonstrations of this technology in the dynamic space. So in the center is a regular image, just under a tomosynthesis algorithm. On the left is the soft tissue, and on the right is the bone tomosynthesis. Many of you can see the future for this type of technology. You could be looking at CBCT as well. So there is quite a bit of potential sitting here. So with that, I will conclude. Thank you so much for attending. If you need to get hold of us, please reach out to KA Imaging. And for RSNA specifically, if any of you are interested, please come by our booth. We've got some of our equipment there and people to show you, booth 7948. There's also a publication at Lakeside in the education session. One of the clinicians and the sites that tried this device in the ICU has published something, so you're welcome to go take a look at that. Thank you so much.